Hello and welcome to the highest yield. In today's video, we will be discussing the chest film. Let's start with the absolute basics. A radiograph, colloquially referred to as an X-ray, is the image that is produced when radiation passes through an object and onto a film or light-sensitive surface. The radiation, in this case X-rays, passes through tissue and produces an image onto film that helpful clerks like you can interpret. The radiograph produced will display many different shades depending on the type of tissue the X-ray passes through. Air and gas are radiolucent and will appear as black. Fat will appear as dark gray. Soft tissue, including the heart and vasculature, will appear as light gray. Bones and fluid will be off-white, and metal, for example from a pacemaker or prosthetic joint, are radio-opaque and will appear bright white. There are tons of reasons why a chest X-ray may be ordered, but some of the more common indications for imaging you'll encounter include chest pain, shortness of breath, trauma, or hemoptysis. Now let's get to the juicy stuff, interpreting the image. While trying to examine everything on a chest X-ray can be overwhelming at first, going through each X-ray you see systematically in the same way every time will set you on the right track. Let's start real simple. Make sure you're looking at the right image for the right patient. There's nothing worse than realizing you spent 10 minutes looking at the wrong X-ray. If you don't already know, always check why the X-ray was ordered, and if possible, check to see if there are any previous images to compare to. Confirm the correct date and ID info. Next up is determining which view of the chest was taken. The view can change how you will interpret the image and which findings may be more visible. For the purpose of this video, we will be focusing on the PA view. PA and AP appear similar but are different views of the chest. In the AP or anterior-posterior view, the X-ray is shined through the front of the chest and passes through the back. The heart may look larger in this view as it is further from the film and casts a larger shadow. This is a portable X-ray, and we often obtain this view when the patient is unstable or unable to mobilize. The PA or posterior-anterior view is the more common standard view. The X-ray is shot through the back and passes through the chest, causing the heart to appear closer to its true size on the film. Lateral views are often performed in series with PA views. This view is useful for localizing findings seen in the PA view. For example, an opacity seen on PA view can be compared with the lateral view to determine which lobe of the lung it originates from. Most patients will be told to inhale and hold when taking an X-ray. This avoids blurring of the image and allows maximum visibility of the thoracic contents. However, occasionally a view of the patient exhaling may be useful for better visualization of pathologies such as a pneumothorax. I know it's been a while since you finished undergrad, but I hope you all remember your ABCs. There are many ways to approach the contents of a chest X-ray, but hopefully this alphabetical approach serves you well. A is for airway. Start by looking for the largest airway in the body, the trachea. Any deviation left or right is important to note. Alveolar collapse or atelectasis can pull the trachea towards the affected lung. A pneumothorax or mass can push the trachea away from the affected side. A deviated trachea is critical to note as it may signify a medical emergency such as a tension pneumothorax and must be immediately treated. B is for bones. Start by inspecting the clavicles. Assess for fractures and check if the spinous processes are equidistant between the median clavicles. If they are not, the patient may be rotated and interpretation will be more difficult. Next up, follow the path of the ribs, starting posteriorly and moving anterior. The posterior ribs will be easier to see, so try your best to follow their path to the anterior. Work your way from top to bottom. The 5th to 7th anterior ribs normally intersect the diaphragm. If the 4th rib or higher intersects, this is a sign of poor inspiratory film. C is for cardiac. If you showed up to anatomy, you'll remember that the heart is found in the chest, so let's start there. This diagram gives you an idea of the anatomical landmarks you'll be able to see. Starting on the patient's left side, the right side of the screen from the top, you'll see the arch of the aorta, the pulmonary artery, and the left ventricle. Check how large the cardiac silhouette is, the opacity that is made up of the heart and the pericardium. If it is greater than 50% of the diameter of the thorax on the PA view, you've got cardiomegaly on your hands. This enlargement of the cardiac silhouette can be caused by something such as heart failure. If the cardiac border is not well defined or is patchy, there may be consolidation in the lung, which may signify pneumonia. D is for diaphragm. The two smooth humps below the lungs are everyone's favorite thoracic skeletal muscle. The right hemidiaphragm is typically higher than the left side because of the liver. Make sure to check the costophrenic angle. This is located at the junction of the costal pleura and diaphragmatic pleura, or more simply put, at the corner of the diaphragm. This angle should be sharp. Blunting of this angle can show collection of fluid like a pleural effusion. E is for equal lung fields. While there are many interesting things to spot in the lungs, we'll just focus on some of the higher yield pathologies today. Pulmonary edema is simply fluid in the lungs. There are many causes of this, the most common being heart failure. There are a couple of characteristic findings of this. The first is this patchy cotton appearance seen in the image on the top left, colloquially known as wet-looking lungs. Parabronchial cuffing seen in the image on the top right is caused by fluid buildup surrounding airways. This gives the appearance of circular airways that are viewed tangentially on radiograph. This is also known as the donut sign. Curly B lines are small horizontal lines seen at the periphery of the lungs, seen in the image on the bottom left. Finally, air bronchograms are caused by the patchy, wet, opaque lung tissue surrounding air-filled bronchi seen in the image on the bottom right. This gives the appearance of an outlined airway. Fluid or pus filling the airspace, most often from an infectious cause such as pneumonia, is referred to as consolidation. Just like with pulmonary edema, airspace opacification in air bronchograms can be seen. Different, however, to the diffuse findings seen with pulmonary edema, pulmonary consolidation from an infectious source is more likely to be unilateral or localized to a lobe. Differentiating consolidation in pulmonary edema from chest X-ray alone can be challenging. It is important to correlate your findings with the patient's clinical findings. Pleural effusions are caused by fluid accumulation in the pleural space. This causes the affected lung or lungs to be obscured by white fluid. A major pleural effusion is immediately noticeable on X-ray, seen on the bottom image. However, smaller effusions may not be as apparent, so be sure to check for other signs. 1. Blunting of the costophrenic angle indicates accumulation of fluid in the pleural space, seen on the top image on the right or the patient's left. 2. Check for fluid accumulation in the fissures between lobes, as seen in the horizontal fissure seen in the top image on the left or the patient's right side. Recognizing a pneumothorax is an important and time-sensitive skill. Look for the edge of the visceral pleura, which should be visible as a white line. No vasculature or lung markings will be visible beyond the pleura. It is important to determine whether it is a tension pneumothorax, which is characterized by mediastinal or tracheal shifting away from the affected lung. This requires immediate decompression, so go find a real doctor immediately if you see this. The image on this slide is an example of a probable tension pneumothorax. Time for the mandatory exit exam. Please take a moment to identify the pathology found in this chest X-ray. If you still can't find anything after watching this lecture, congratulations. This is a normal chest X-ray and you have passed. Thank you so much for taking the time to watch this lecture. I hope the chest X-ray is slightly less bewildering to you than it was 5 minutes ago. This has been The Highest Yield.